topic. So next speaker is Dr. Debasis Chakrabarti, who will be speaking on diagnostic evaluation and the management options available. Debasis, please carry on.
Thank you, Dr. Mandal sir, for giving me this opportunity. Good afternoon, everybody. So I'll be speaking on the clinical evaluation and the surgical options for primary congenital glaucoma. Dr. Murli had already covered some of the clinical features related to primary congenital glaucoma. So the classification of childhood glaucoma according to the Collaborative Glaucoma Research Network, as we all know, we classify the pediatric glaucomas as primary childhood glaucoma and secondary childhood glaucoma. Out of this, primary congenital glaucoma is a specific entity. This is the most common form of developmental glaucoma, and the etiology is isolated maldevelopment of the trabecular meshwork, which is also known as isolated trabecular dysgenesis. It's not associated with other developmental or ocular anomalies or ocular disease, and there are three variants based on the age of presentation. Either it can be a newborn onset, that is 0 to 1 month, or infantile onset between 1 to 24 months, or late onset or late recognized, that is more than 2 years of age. Why is clinical evaluation so important? Number one, prompt diagnosis of childhood glaucoma and appropriate treatment can minimize the degree of visual impairment, because if it is diagnosed at a later stage, there would be permanent scarring of the cornea and permanent damage to the optic nerve. Number two, please beware of the mimickers, like Dr. Murli had discussed some of the causes of corneal clouding. Similarly, there can be retinoblastoma, which can sometimes mimic as primary congenital glaucoma, and the consequences may be disastrous. Now, regarding the clinical evaluation, as we all know, it is the congenital glaucoma is an IOP related damage to the eye, but sometimes the measurement of the intraocular pressure itself under conditions of examination under anesthesia is fallacious, and therefore we have to go by other surrogate measures that Dr. Murli had just discussed. So look for other signs of glaucoma in this age group, like ocular enlargement, hub striae, and increased cup disc ratio. What should be our aims of evaluation? To confirm the diagnosis, to distinguish between primary and secondary developmental glaucoma, to establish the baseline parameters, to assess the severity and prognosis, to rule out ocular and systemic comorbidities, and to rule out space occupying lesions. Regarding the history, some of the salient points which we should be specifically be looking for are age of onset of symptoms and signs, the symptoms like epiphora, photophobia, and blepharospasm, and corneal opacity. Rarely, a red eye can mimic a congenital glaucoma like conjunctivitis. We should ask about problems during pregnancy, example rubella, delivery history such as use of forceps, family history like parental consanguinity, and history of glaucoma in the siblings. Regarding the symptoms, the classical triad of symptoms are epiphora, photophobia, and blepharospasm, which is attributable to the IOP-induced corneal epithelial edema. However, in the Indian subcontinent, the most common presenting features are large eyeball size and hazy eyes. And sometimes it can present as acute eye drops, as already shown. We have to assess the vision by age-appropriate techniques. I will not go into the details. The key to diagnosing primary congenital glaucoma is doing a proper examination under anesthesia. So we should do the refraction, document the corneal findings, measure the intraocular pressure, do the gonioscopy, look at the fundus, and take the decision for surgery. Usually the examination under anesthesia and the surgery is done in the same sitting. These are the requisites for examination under anesthesia: a pediatric speculum, irrigation fluid, calipers, tonometers, ophthalmoscope, retinoscope, gonio lens, and if necessary, we have to do an ultrasound pachymetry and B-scan. What is the choice for the anesthetic agent? The type of anesthesia and the type of tonometer are important. All anesthetics and sedative agents lower IOP excepting ketamine, chloral hydrate, and benzodiazepines. Sevoflurane is the most commonly used inhaled agent due to its convenience and safety profile. And the most important thing is to assess the intraocular pressure as soon as the child stops moving after inhaled anesthesia and prior to intubation, or else the measurement will be fallacious. Now, the most relied upon instrument for measuring IOP in children is the Goldman applanation tonometry and the Parkins. So in the examination and anesthesia, we usually use the Parkins tonometer. The other options are the tonopen and the IKEA tonometer. Now, corneal haze, Dr. Murli has discussed in detail. It is representative of the severity of glaucoma. Usually it's more in center, and we can document what are the other posterior structures that are visible. to assess the severity of the glaucoma. The corneal edema in primary congenital glaucoma is a simple epithelial edema due to elevated IOP. Subsequently, there is permanent stromal edema, and untreated, this edema progresses to stromal scarring. Now, the corneal diameter is very important. The corneal enlargement secondary to elevated IOP usually occurs before 3 years. We measure the horizontal visible corneal diameter white to white. The normal is about 10 millimeter at birth, and it's important to remember the abnormal values, that is more than 11 millimeter in the newborn, more than 12 millimeter in a child less than 1 year of age, and more than 13 millimeter at any age. The hub striae are pathognomonic. They are concentric to the limbus in the periphery, but when they are in the center, they usually run across the visual axis. In contrast, the decimus breaks that occur due to forceps injuries, they are vertical, unilateral, central. They have a normal corneal diameter and as often associated with periocular bruising. The classical feature of gonioscopy is that in the normal newborn eye, the iris has recessed beyond the scleral spur, so the scleral spur is visible as a whitish band. However, in primary congenital glaucoma, the peripheral iris inserts through the trabecular meshwork, and we are usually not able to visualize a scleral spur. The fundus examination should always be done. We should look for cupping and focal areas of rim loss. A cup disc ratio of more than 0.3 in an infant or more than 0.5 in an older child is suspicious. At the same time, we should look for other signs like a choroidal hemangioma, which may be a sign of Sturge-Weber syndrome, or pigmentary retinopathy of congenital rubella. And we have already discussed that striking reversal of cupping can occur after successful glaucoma surgery. The pachymetry is not so important in pediatric glaucoma. The definitive role is uncertain. However, the CGRN recommends that CCT should not be used to adjust an IOP measurement, but it should be rather taken into consideration in the overall context. The axial length, on the other hand, is very important in pediatric glaucoma, although the absolute value may not be important and it usually decreases after surgery. But even after successful glaucoma surgery, that IOP may increase, and increase in the axial length on sequential examination is a sensitive indicator of progression of glaucoma. B scan should be done in absence of good view, and it can provide critical information about the space occupying lesions, and it's very important to rule out retinoblastoma. Now, the differential diagnosis of congenital corneal clouding has already been discussed. According to one study, the most common differential diagnoses were Peters anomaly, sclerocorneal, dermoid, congenital glaucoma, birth trauma, and metabolic disease. And there is a mnemonic to remember this: S for stumped, S for sclerocornea, T for tears in the decimus membrane, U for ulcer, M for metabolic diseases, P for posterior corneal defect, E for endothelial dystrophy, and D for dermoid. Coming to the surgical options for primary congenital glaucoma, as we all know, it is basically a surgical disease, and eye drops are started just to buy some time till the child is fit for anesthesia. The surgery is the mainstay of treatment. It's almost inevitable at some point of time, and we should always remember that's the first surgery that has the best chance for success. It should preferably be performed by a trained surgeon with adequate surgical skill and experience and at a safe anesthetic setup, and it's certainly more challenging than adult glaucoma surgery because there's a lot of variation in the limbal anatomy. So what are the surgical options? So there is a plethora of surgical options for congenital glaucoma. It started all with goniotomy, then we have the trabeculotomy ab externo, then trabeculectomy, combined trabeculotomy and trabeculectomy, 360 degrees trabeculotomy using blunted proline, endoscopic goniotomy, fiber optic microcatheter trabeculotomy, and for recalcitrant cases we have the tube shunt implants, and we have cyclodestructive procedures. What are some of the general considerations? The angle surgery, that's goniotomy and trabeculotomy, is the procedure of choice for primary congenital glaucoma. What should be the exact choice, whether it's goniotomy or trabeculotomy? It's dictated by the corneal clarity, surgeon's experience, and preference. The anatomical factors that would guide us are the cornea are: number one, corneal clarity. If the cornea is clear, we can contemplate goniotomy, but if the cornea is opaque, goniotomy cannot be done. We have to do either trabeculotomy or combined trab and trab. If it's a scurred conjunctiva, we cannot go for a trabeculectomy, and better to go for a tube. The success for the angle surgery is high, almost 70 to 90% in favorable cases, and it is thought to be determined more by the severity and the duration of the disease rather than the type of surgery. So in goniotomy, basically we have to do intraoperative gonioscopy, and now in the age of MIGs, we are all being accustomed to this position where the head is tilted away and the surgeon's head is in the opposite direction, and then basically we have to incise the angle either using an MVR blade or using a 23, 24 or 25 gauge needle. This is the conventional trabeculotomy, where the Schlemm's canal is opened up and a metal trabeculotome is inserted, and the Schlemm's canal is ruptured from outside. This is the trabeculectomy technique. It is almost like what we do in an adult glaucoma surgery, and the combined trabeculotomy and trabeculectomy is by far the most commonly performed surgery in our setting, where the corneas are usually hazy, and it targets two pathologies. The trabeculotomy is for the angle anomaly, whereas the trabeculectomy is for the pathology in the collector channels and beyond. And then we have circumferential trabeculotomy, which targets 360 degrees rupture of the Schlemm's canal, either using a blunted suture, example 6-0-Prolene, or using an illuminated microcatheter. And in cases where the first surgery has failed, we can go for the glaucoma drainage devices. There are certain settings where the glaucoma surgery, where the glaucoma drainage device can be used as a primary surgery, for example in axonal rigor anomaly or in Sturge-Weber syndrome, and the implant used is either a pediatric Ahmed glaucoma valve, or we can use the other implant. Now, a new technique has been popularized by Dr. Mandal, and I'm sure he would see it in his presentation. This is called the IMPACT, that's illuminated microcatheter passage assisted circumferential trabeculotomy and trabeculectomy. So that is the end of the discussion. I discussed the clinical evaluation and the various surgical options for primary congenital glaucoma, and Sir and Madam would go into the final details of the surgery. Thank you.
Thank you, Debasis, for giving the detailed description of the